Hello and welcome to Back to Fitness. This is Education Week 1 delivered to you from Southport and Ormskirk NHS Trust and the Joint Health Department. There's 4 sessions that we're going to run through. As you can see in front of you, week 1 is types of lower back pain and trying to categorise different types at different severity of painful complaints and looking at our rationale for imaging, our rationale for radiological evidence, why we may or may not send you on for x-rays, MRIs, etc. And then also looking at the prognosis of your lower back pain, where your lower back pain sits in a nation of average, and trying to plot you out within that, and hopefully doing a little bit of myth busting in there as well. And then week 2 we'll concentrate on pain mechanics, looking at the physiology behind pain, how that can affect your back and how we can influence that pain mechanism. Then in week 3 we're going to concentrate more on the benefits of exercise, benefits of pacing, managing flare-ups, pharmacological treatment and management, etc. And then week 4 is very short. We're just looking at goals for the future and integrating third sector information in there. So essentially, what services can you access within your locality to continue with the exercise that we hopefully should start with you here. So we'll move through the presentation today. Hopefully you will have your exercise program already sent out to you either via Physitracker or in the post, and if you've not, then get back in touch with your physiotherapist or your initial referring physio. Here we're looking at what is lower back pain and what percentage of people have certain pathologies of lower back pain complaints. So the biggest figure, 85%, is that of our patient population that has multifactorial lower back pain complaints. And essentially what this means is there's no one structure that is to blame for your lower back pain. So in 85% of cases, it's not a slip disc, it's not a degenerative spine or a crumbling spine or all these other harmful words that are sometimes used or associated with lower back pain. There's several factors that will influence the severity of this pain: muscle, soft tissue, connective tissue, bone, etc. And that's the majority of patients, and that's probably the majority of you watching this if you've already been referred onto our program here. 15% then have specifically related lower back pain complaints, and that could be stenosis or canal stenosis of the vertebral column itself. That could be a slip disc or a protruding disc. It could be a neural pinch or a sciatic-like pain or a radiculopathy. But that's only in 15% of cases where we see such specific pathologies. So if you do feel like you're one of those patients that's concentrated on one specific pathology for an awful long time, if that period of time is longer than a year or so, then it's more than likely you fit more into the 85% because of the changes that will occur in your back after that initial pathology. And bearing in mind, you can slip from that 15% of specific pathology into the 85%. Should your back pain change or should it continue or become chronic. And then of course we have our red flag patients and our red flag pathologies, our serious pathologies. This makes up less than 1% of the patients that we see coming through our department, and we're constantly screening for these patients when you come in for your assessment and when we talk to you over the phone. But that's not something to be concerned about. We just know that there's a very small percentage of our population that have red flag and medical emergency lower back pain complaints, things like Cauda-Equina syndrome. And if you're concerned about anything to do with Cauda-Equina syndrome, then just give it a quick Google. But remember, it's very, very unlikely that it is going to be, and if you have any further concerns, either talk to your GP or talk to your physio. So in terms of prognosing our multifactorial lower back pain complaints, this puts into context the normal recovery time. So approximately 40% of people that complain of this multifactorial pain resolves within 7 days, 75% resolves within a month, and 90% resolves within 6 to 12 weeks. And that's partially to do with different healing phases, but also partially to do with how people approach treatment for lower back pain. So without advice, people normally are in pain for a short period of time and then gently and slowly but surely get back to normal routine, building strength back up, etc., to the point where their pain is no longer a problem. And 6 to 12 weeks allows for an inflammatory process to occur, allows for a healing process to occur and then a remodeling or strengthening process to occur as well. And that's normally why those 90% figures are quite high. However, 25% of those patients have a risk of recurring back pain complaints within 1 year. That could be down to lack of proper conditioning post initial complaint. It could be that an activity that you were avoiding for a long time you went back to and then caused a flare-up. It's difficult to be really specific with those recurrences, but you are about 25% chance risk of recurring. And then 10% becomes chronic, so 10% becomes a problem that lasts longer than 12 weeks. Chronicity doesn't have any relationship with pain. All chronicity means in this context is the length of time, and that length of time is 12 weeks and over. So in this next slide, we're looking at the rationale for imaging. And in table 2, as you can see, the title there is Age-Specific Prevalence, Estimates of Degenerative Spine Imaging Findings in Asymptomatic Patients. And this systematic review was done in 2014, and it is purely just looking at MRI imaging results in a cohort of 3,110 people. And the key part about these 3,000 odd people is that they had no back pain. These were healthy population patients with no back pain complaints. And as you can see in that table there, it really just starts to contextualise a little bit the higher percentages of degeneration, disc signal loss and disc bulges as we age further. So 80% of 50-year-olds have disc degeneration and 60% of 50-year-olds have a disc bulge. So you're talking about 8 in 10 people have some form of osteoarthritis in their spine if you're over the age of 50, and 6 in 10 people have disc bulge, and these are people with no back pain. And take some time just to look at some of those numbers and see how high they are, especially as we start to get older. But even for those younger age groups, 20 to 30, 4 in 10 people have osteoarthritic or degenerative change within their vertebrae and aren't experiencing any pain or problems. So this kind of links into that multifactorial lower back pain approach that, yes, the MRI or the X-ray scan might show some osteoarthritic change, some degeneration or some disc bulge, but that doesn't directly correlate to our painful symptoms, and that doesn't directly correlate to the injury or the thought of the problem that you may have in your lower spine. It's really important to think about that lumbar spine or your lower back as a strong adaptable structure, because it's covered in really strong muscle. It has to be, because it's one of the main pivot points of our body, and we use our back all the time, and it is very strong as a structure. We need to have a little bit more belief in how we can get that structure stronger and help it support our spinal column and our vertebral column. So out of that slide, I just want you to take really that despite all these words like degeneration, signal loss, bulge, protrusion, degeneration, etc., it doesn't directly link into our pain, and we can't treat your MRI scan if it tells us these things. We can't treat that problem. We need to treat this overall holistically and look at the problem from a wider perspective. Most importantly, putting the patient first and treating the cause of those painful symptoms and the possible reasoning for them being more or less painful, and not simply treating the MRI or the X-ray. Having said that, rationale for investigations is still something that we take very seriously. And realistically, we're looking to send people for X-ray, bloods, MRI immediately if we feel that there is a sinister pathology or a chance of a sinister pathology that may need surgical intervention or may need quicker medical intervention. But we're not going to send everybody for a scan. And most people over the age of 30, as we've seen from the last slide, show changes on an investigation anyway, and that's nothing to worry about. That's just part of our aging process. It's the wrinkles inside the back that we can't see. It's that dry skin that you try and apply cream to on the outside. It's not really a problem. It's not going to affect your function. What's more important is how we can strengthen, adapt and move forwards with your back and with your painful problem. But this slide really is just to symbolise that if we do even feel in the smallest degree that there may be something serious going on, we will never hesitate to send you for a scan. We will never hesitate to send you for further radiological investigation and then treatment should it be needed. But having said that, we don't routinely scan these patients and people with multifactorial lower back pain for the reasons we've given. If your lower back pain problem has been occurring for a prolonged period of time, this has been discussed with your therapist, and we feel like we're not getting anywhere with this problem, or symptoms are getting worse, symptoms are changing, then of course discuss it with your physiotherapist and we'll try to create a plan for you. We're not against scanning people, we're just against scanning people inappropriately, and then it's starting off this kind of process of myth busting, which is often what we need to do, because people can commonly find something very small on the scan, hold on to that information and blame that as the sole cause for all their pain, but really we're in control of it more than that, and that's what we're trying to help you do. And as we move into week 2 and 3, we'll talk a little bit about pain and how else our exercise and what else we can do to implement to help that as well. As always, if you have any questions, then first off, see if you can find any resources online. Head to our website, Southport and Ormskirk Hospital, the physiotherapy section there, or head to your physiotherapy department phone number and give us a call if you have any further questions. We'll see you next time.